Good morning. Welcome to the Stinson Visiting Professorship. We've had a visiting professorship that generally focused on translational surgeon scientists. And last year, Mike Fishbein and I thought about this, and we really wanted to honor Ed Stinson. And, we thought, well before the term translation was popular, Ed Stinson was doing this. Now, Ed Stinson was a chief resident during Dr. Shumway's very first heart transplant here at Stanford. That was 1968. And, Dr. Shumway's credited with inventing the operation and moving it forward. Ed Stinson did a lot of the work in the lab before and afterwards. And not only in the lab, but in the clinical environment, and served as the principal investigator for a PO1. That's a giant RO1 for many, many years, decades afterwards, to really move the science of heart transplantation forward until almost 15 years later did heart transplantation become really like a gold standard, widely adopted therapy. And that's really a lot of the stuff that's not very well known. And Dr. Stinson really deserves a lot of credit for pushing heart transplantation forward. There's one fun fact, and that is he's also a co-author on the other topic that Stanford's really well known for. So Stanford's really well known for heart transplantation, but then of course, all the innovative work in aortic surgery, and particularly the 1970 publication that determined the classification system for aortic dissection, type A and type B. So if you're anywhere in the world other than Houston, Texas, you use the Stanford classification system. And Dr. Stinson is a co-author on that paper, and he's the last living co-author on that paper. And not only is he living, but he's alive and well. And Dr. Miller and I just saw him 2 months ago here on the campus as he was receiving an award from the School of Medicine as one of the most distinguished alumni. And Dr. Stinson is quite engaging and very fun to speak with. And he was very, very honored to have this professorship named after him. And so when we were thinking about, well, who would be the perfect person to bring as the first Stinson lecturer? And it didn't take us long. And we said, well, obviously, it's Pedro del Nido. There's really no one in our entire larger specialty that embodies clinical skill, scholarship, mentorship, and leadership. All the things that Stinson represented are packaged in Dr. del Nido. And in our modern era, there really is no one quite like Dr. del Nido. Now, he is the chair of cardiac surgery at Boston Children's, arguably one of the greatest congenital heart surgery programs in the world. And, he's a very talented surgeon. Many, many different techniques and skill sets across the entire spectrum of congenital heart surgery, a real innovator in valvular surgery in children, particularly complex valve repair. He is a scholar. He has over 600 publications to his name, 600. Think about that. Some of us are working on 6. He's got 600. He's also served in multiple capacities at the NIH. And as a scientist, he is very well known for something. So imagine having your name spoken in just about every single operating room, every single day. When Dr. Chitwood was here as a visiting professorship, I told everyone that, we use the word Chitwood quite often, right? We always say Chitwood, and then they hand you a clamp, right? But that, occurs in a small subset of the ORs. Well, think about del Nido cardioplegia. Not only do we utter that word, his name, every day in the OR, but we utter it multiple times. We say, antegrade del Nido, and someone else says antegrade del Nido. And then when that's done, you say retrograde del Nido. And then, you give retrograde del Nido. And then later on during the case, you might say, give some more del Nido. And so the term, your name, is uttered so many times. And the best thing I like about this is about 10 years ago, I was using Del Nido, and Dr. Del Nido came up to me in Japan. We were at a meeting, and he said, you're using it incorrectly. It's meant for children. It was never meant for adults. And I said, well, it's too late. There's probably, millions of cases going on in the United States and, elsewhere in the world every day where they're using Del Nido in adults. It's sort of gotten out there. And then when he heard about retro Del Nido, he's like, oh, this is totally, it's been totally, there's been a bit of indication creep. So, that's Pedro as a scientist. As an engineer, he's developed multiple innovative devices. You're going to hear a little bit about something that I've been keeping track of for quite some time, and that is an expandable heart valve. It makes total sense for children. But if you think about it, not only would it work well in children, there would be multiple applications in adults. Right now we're doing TAVR valve and valve. Well, imagine if the valve that you're TAVRing into started as an expandable heart valve. Then you could get multiple TAVRs in there. He might put all of us out of business because everything's going to be TAVR valve and valve and TAVR valve and valve. As an inventor, he's created multiple startups, spun these out to be full-fledged companies. He's a mentor. He was a mentor specifically to our Christina Green and our Peter Chu, who I think many of us remember quite well. And as I hear, Dr. Peter Chu is doing quite well under Dr. Del Nido's leadership. As a leader, national leader, Dr. Del Nido was very instrumental in major advances at the American Heart Association, and then, of course, at the AATS, where he rose to presidency. And he has been an advocate for many of us in this audience and throughout the nation through the AHA and the AATS, and we're all very grateful. And then lastly, I think most importantly, Pedro, you are a friend, a very close friend to me, to many of us here, and I think that's the thing we value the most. And thank you so much for joining us.
Thank you, Joe. That was a very, very kind introduction. I'd like to say, first of all, it's an enormous pleasure and honor to be here. I've never been to Stanford. Obviously, I've heard of Stanford my entire career, but it's a privilege to be here. The capacity of this institution to generate not just novel ideas and novel therapies, but to generate individuals who make a difference is outstanding, and something that you all should be extremely proud of. The topic that I was asked to talk about is something that I sort of dedicated my last, I would say, decade and a half to working on. And I'll talk a little bit about why it's become an important topic for me, and I think an important topic for our entire field. And that is heart valve disease. It impacts, I'm going to talk primarily about the young, and as I get a little bit older, the young begins to creep. So I'll say a little bit about adults as well and how this technology will impact adults. But there's a lot going on. There's a lot going on here. There's a lot going on all over the world. And I think in 5 or 10 years, we're going to have very different technology available. So let me walk you a little bit through it. These are my disclosures. These are all startup companies. Most of them are pediatric. And the main reason for that is that nobody else does anything for pediatrics. And so you have to do it. You have to create the technology, you have to create the company, and then convince the rest of the world that, yeah, it's a good thing to do. So that's what all of these are. Autis in particular is the valve company that Joe alluded to. I'm not going to discuss the activities of the company at this stage. I'm just going to talk a little bit about the technology, the concepts behind it, in the context of a lot of the things that are changing now. The other ones have no relevance to this presentation. So this is the outline. I think it's important to just give a background of what are we talking about here? What do we mean by valvular heart disease? Because I think it's important to think about it in that context. We do have to talk about reconstructive. It's not just about replacement therapy, but there's a huge amount of work being done in reconstruction, and I would dare say It's probably the most exciting area that we've been talking about for the last decade. It's made huge advances, but there's a lot more coming. And then finally, I will talk about devices, about how we're thinking about devices and what's new, what's coming. So let's start off with a need. This is a very important summary here. And this is the adult summary of the most common types of diseases that we see of valvular heart disease. Everyone talks about calcific aortic valve disease in the adult. And as you can see, this is age on the y-axis. This is population. And as you can see, as you get older, this is a disease of the aged. Degenerative mitral valve disease, in fact, if you look at the numbers, is actually much more common, at least in the Western world. It's much more common. And it's also a disease of the elder, but you begin to see it much younger. And if I were to separate out in this process, you have women and men. Women actually have more mitral valve disease than men do. And this is something that's being studied in a number of different ways. But the one that nobody talks about is this one, and that is rheumatic heart disease. And these numbers, although they don't seem very large, in fact, they're way, way underestimated. In fact, it's the fastest growing valvular heart disease that we see. And the reason why we don't talk about it is because it's in a different part of the world. And then the area that I'm interested in, and I've been working on, is way down here. That is this congenital valve disease. It's a rare problem. But I would argue it's a lifelong problem. And for that reason, the economic impact, the social impact, and just the health impact is way out of proportion than valvular heart disease is in adults. This is kind of the distribution prevalence. This is the distribution prevalence for calcific aortic disease. And you can see in darker is a higher. It tends to be a problem of the Western world. In more developed countries. Certainly, if you look at mitral valve disease, it definitely is a problem of the Western world. But if you look at rheumatic disease, it's a problem of the developing world. And there are areas of the developing world where there's very little that's being done. In fact, the only country that really has been addressing it in a very systematic way has been South Africa. But there's a huge need. And the need is the same. A valve is a valve is a valve. And so that's why we decided that we wanted to pursue this. If you look at the numbers, rheumatic disease affects 39 million people. Each year, we lose about close to 300,000. And most of these are in younger patients, 25 years or younger. So there are many similarities to congenital heart disease here, and certainly an area that we wanted to look at. Now, there's been ongoing controversy as to what is the best way to treat rheumatic valve disease. And this is probably the best study that I can, in most recent study, where it really, if you think about it, it explains the whole problem. This is from Malaysia, huge experience. And this is the survival curves for 3 different types of treatments. In green is bioprosthetic valve, in red is mechanical, in blue is reconstructive surgery. And if you look at this chart, you say, hey, it's a no-brainer. Reconstruction's the answer for these kids. Until you really begin to understand that, okay, how many patients? 419 over a period of several years. It's because the expertise that's required to do a true reconstruction is very limited. And so you cannot scale it up, at least not with current technology. And that's the fundamental problem that we face. And it's true, by the way, of adult mitral disease as well. If you really want a mitral valve repair that's going to be durable, there's a handful of centers in North America and in Europe that really can guarantee you a good result. And that's it. And then the vast majority are doing 5, 10 mitral operations a year. So this is the fundamental problem here with this repair. Yes, if you can do it, it's the ideal, but only a very select group of kids. And certainly if you're going to go to a place like Africa, where even having a bypass machine is a challenge, that's not a solution. We need to come up with a better solution. So yes, we do need to be able to take the knowledge that this individual has, Dr. Yakub has, and his skills and his brain and his hands, and try to figure out a way to democratize it, how to get it. And I'll show you ways that we're working on that. But the other area that we need to work on is actually a prosthetic valve. Now, what about congenital, which is obviously my passion? Well, first of all, I think it's important to state that congenital heart defects are the most common of all birth defects. Okay, we don't talk about it very much, but it is definitely the most common birth defect. And if you look at how many patients worldwide, it's at least that many, 1.35 are born every year. But if you look at valvular heart disease, it accounts for about a quarter of congenital heart disease in one form or another. And usually it's associated with something else, like in tetralogy, it is valvular disease with a hole in the heart. But valvular heart disease is the component that actually impacts the kids long term. What is our therapy? Well, this tells the whole story here. So this is a study, this is a Sendika study from Europe. This is a collaborative study, multi-center. There are thousands of patients that were enrolled, different ages. And what they looked at is freedom from reoperation. And what they demonstrated here that this is bioprosthetic valve, this is homograph. If you're a 1-year-old and you get a bioprosthetic valve or you get a homograph, there's 100% chance that you will need an operation within 5 years. Okay. And if you're a 6-year-old, there's 100% chance that you will get another operation within 10 years. And it isn't really until you get to almost adult age, 25 to 40, that you begin to see some degree of durability of the bioprosthetics. So what's the consequence of that? Well, one alternative is to use a mechanical valve. Well, the problem that is it doesn't account for growth. You still have the same growth problem. So if the child, you put in a great valve, you say, don't worry, it doesn't need to be, it's not going to degenerate, but they're going to outgrow it. So you're not going to fix that curve by simply a different type of valve. So what happens? Most of the kids don't get anything. The surgery is delayed. Tetralogy fellow is a perfect example. Most kids are left with free pulmonary regurgitation. And their ventricles dilate over time, and then we argue about when to intervene and when to put in a valve. That's not really the way we should be treating kids. We should be giving them a valve, but then a valve that can grow with them and can last their lifetime. So that's the real challenge for us. So for kids, heart valve disease is a completely different paradigm. Unlike the adult, somatic growth is a huge challenge because whatever you build, you have to build, take into account the fact that that child's going to grow. That prosthesis has to grow with them. Durability is a challenge. If you're 80 years old, you get a valve that lasts you 10 years, you're done. If you're 8 years old and you get a valve that lasts you 10 years, you're seeing multiple procedures the rest of your life. And the likelihood that you will survive all those equal to the rest of the population is pretty low. So what do we do about that? Well, it's not as if kids are the only ones who have this problem. If you look at the adult world, and if you look at what current prostheses are doing in the adult world, the problems aren't a whole lot different. We don't talk about it very much. If you look at things like structural valve deterioration, I think as Joe pointed out, jokingly said, one of the fastest growing operations is removal of TAVRs. Why? Because they deteriorate in adults. Okay, so that's a problem. The other, which is, I think, an even bigger problem, is patient prosthesis mismatch. That is, a valve that's too small for the body surface and the needs of that patient. And so you get a residual gradient. That ventricle is never relieved of its extra work, and therefore they never recover. And the long-term consequences of that are large. We barely talk about it, but it's actually a huge, huge problem. So a lot of the technology that we're developing for kids may actually, in fact, as Joe said, impact the adults. So let's dive into this a little bit more. Let's start with reconstructive technique. Where is the world going? Well, as everyone knows, imaging has revolutionized our world. The idea of having a very detailed view of the three-dimensional anatomy of a structure inside the heart before you even walk into the operating room was inconceivable 10 years ago. Today, it's almost malpractice not to do it, okay, because the imaging has gotten so good. This is something that has really changed everything that we do. And the ability to take medical imaging and do analysis of it on it is also exploding. So we can visualize what the problem is well before we actually get into the operating room. And that's true not only of valves, it's virtually everything that we do in congenital. So even things like coarctation, we can actually come up with exact geometries of the patch in order to repair an aortic arch, whether we're considering some very complex tunneling between a ventricle and an aorta, the patch can all be planned out ahead of time. And whether you're trying to analyze in a Fontan circulation where the connections of the hepatics should go so the hepatic factor gets distributed to both lungs, this is all can be calculated ahead of time. So this is where our world is right now. And so we can simulate. And this was the first time we'd actually beginning to talk about simulation, but real simulation now, long before we get into the operating room. So I'll walk you through a couple of examples. This is a typical presentation of a patient who everybody can see has exactly one problem. He's got aortic valve regurgitation. So we know we need to do something. There's a problem there, but we don't know what to do. This image, which is from the same patient from a CT scan, tells us how to fix it. Why? Because now we can see, because there's two pretty good leaflets, there's really the problem is this anterior leaflet that is the source of the problem. But it's a little more complicated than that. There's a geometry that's involved, but that, again, that can also be analyzed. So we know that there's a certain height that you have to achieve, a geometric height, in order to get a long-term durable result. The height of the commissures has to be very precisely calculated, but all of this can be done, and we know exactly what works. If you have a sinutubular, if you have an annulus diameter of 18, you need a sinutubular diameter of 25, and all of this is in formula. So you can actually, now there are apps that we use in the operating room where we plug in what we measure and they tell us exactly how big these leaflets have to be. And so if you're doing now some of the procedures that are more innovative, such as the bicuspidization, which we've started to do quite a bit now, following the group in Germany, who's had thousands of patients enrolled in this type of. We can actually calculate exactly how big this patch needs to be, or what the angle or orientation of these leaflets have to be in order to get a good long-term result. So this is where this field is now. So reconstructive aortic surgery is no longer let's look in and see, and let's figure it out while we're in the OR. It's, no, you've planned this out long before you get into the OR. There's always some nuances that you find in the OR, but by and large, you're not walking in blind. The tougher area is AV valve surgery. We call it AV valve surgery because it could be anyone in our field. This could be a left ventricle, it could be a right ventricle, it could be a combination of both, or it could be a common ventricle. But the inlet valve problems are often the same. And that is, it's a parachute-like structure with a big leaflet and a support structure, which is critical in order to get adequate coaptation. So that entire geometry is much more complex, obviously, than a semilunar valve. So here, imaging has made a big difference. We can take these structures, we can render them. This is a canal-type valve where you really have effectively 3 leaflets. This is a patient who had a repair. And then we can actually analyze what the problem is. We can see that there's, there may be a perforation there, but we also see that there's a gap in the center of this valve, and understand exactly what we are likely to find at the time of surgery. Well, this is a surgery on that patient. And we were looking at the same leaflet. By the way, this is where the conduction tissue is. We marked it right there. So that's an area we want to stay away from, because in canals, it's unpredictable. There's the perforation that we saw there. So the imaging actually gave us a pretty good idea. We knew exactly what we were going into and we had the confidence to understand what needed to be done. Okay, so now we can see, but what do we need to do? Well, you can do quantitative analysis as well. And this is something that Rena Ghosh in our group, she's a pediatric cardiologist, she's a research cardiologist. And what she does is she's developed this algorithm for actually giving us all the information. Just like we had information about how to reconstruct the aortic valve, you can do the same thing for the mitral valve. And you can look at effective orifice area and all of the parameters that you need in order to decide how to reconstruct this valve. And then we can go one step further. We know, as I said before, that we can do analysis of this valve in the sense that in this case, for example, we had a patient with congenital mitral stenosis where the papillaries go right into the leaflet. There's no cords here. But in addition to that, there's an accessory papillary muscle attaching to the posterior leaflet. This posterior leaflet was immobile. We had prolapse. So we had two problems, combined stenosis and regurgitation. Well, this is a very challenging valve because what you really want to do is you need to release this leaflet so it actually begins to coapt, but you also need to replace this because you cannot leave the papillary muscles as an extension of the leaflet. The leaflet will be immobile. So we're going to have to replace them with cords. Okay, how are we going to do that? Do we eyeball it in the operating room? And that's really hard. But with simulation, we can do it. And so here's what we said to Rena is, look, I need to cut off these papillary heads. I need to know the distance between the wherever I cut off and the annulus so I can decide how long my cords have to be. And so she came up with this number, 10 millimeters for that cord, and essentially 11 millimeters for the other. So we knew ahead of time roughly what was going to work. There always is some tweaking involved. There's always some adjustment, but by and large, you're at least in the ballpark. And that is something that now is here. And so to be able to do that for a complex valve or to be able to do it for a conventional adult valve with a fairly predictable set of pathologies, I think is something that's just here. It's available. We just have to set ourselves up to do it. And it's not that complicated. So this is where I think the repair valve work is going to go, the reconstruction. The beauty of that is that if we can do this, then we don't have to rely on high degree of expertise, someone who has 300 mitral valves under their belt before they can do the next one. Okay, because now all of a sudden it begins to democratize the field. People who don't have that much experience can plan this and analyze this. And even in some centers, there's actually a physical simulation. They produce 3D models, they actually practice, and they go to the OR. So you can do whatever you want, but now suddenly it levels the playing field. What if we can't repair? Well, this is where I want to talk about what at least my view, what the heart valve of the future is. And in order to talk about it, we really have to think about it in three components. There's the materials, what is the valve made of? The design, how does the valve work? And then the delivery system, it's how do we get that valve into the position? I'm not going to talk, since I'm a surgeon, I know what the delivery system is. It's called suturing. So I'm not going to talk about transcatheter delivery, but I'm sure somebody else will figure that out pretty quickly. So first of all, let's start off. What's our goal? Well, our goal is to come up with an optimal valve. And what does an optimal valve mean? The durability's got to be greater than 15 years. Okay, and that means that certainly if you're a young child and I put a valve into you, I don't want to see you again until you're an adult. Okay, and that would be my goal. And certainly if I can get that in a young child, in a 40-year-old or a 50-year-old with a bicuspid aortic valve, then that may be a lifelong solution. That would be the ideal. It incorporates into native tissue, so the biocompatibility is what we need and doesn't activate platelets or coagulation cascades, so we don't need anticoagulation. Maybe you need antiplatelet agents, but that's about it. But really, it's the optimal flow dynamics so that we have an effective orifice area that's appropriate to that patient. We eliminate the problem of patient prosthesis mismatch. And what is that ideal prosthetic valve? Well, ideally, the inside diameter, outside diameter is minimized so that what you actually put in on the outside is the way our valve works. Our valve, the aortic diameter is what you have when your leaflet's fully open. There isn't a single prosthetic valve that does that today, but that's where we need to go. We need to have a valve that's adaptable to a calcified annulus. That's an adult problem, but nevertheless, it's an important one. And the one that I'm very interested in is I need to be able to manufacture it at a low cost. If I need to kill 17 cows in order to make one bioprosthetic valve, which is the current industry standard, 40% of the valves that are finished, made, get discarded because they're not perfect. That's the problem. You cannot manufacture a valve that's cheap because the process of making it is so expensive. But if I can manufacture a valve for under $100, which, by the way, I'll show you a valve that costs that, uh, it's a game changer for the rest of the world. So leaflet material. Well, the traditional way that we have thought about leaflets and leaflet of the valve, it's either human from autograft, from an allograft, I mean, or from an animal. In this case, either porcine or bovine pericardium. We can construct 3 leaflet valves, 4 leaflet valves, whatever you want, but we're using that same material, or it's pyrolytic carbon. Those are the materials that have been used for the last 50 years and continue to be used. The valve design is almost always the same. It's 3 leaflets, it's flat. There are very few valves in our heart that are flat, but these are flat. And so what we do is we force them into that position, and that's the end of the story. Or there are 2 leaflet valves, which is what most mechanical valves are like, and that was simply done based on flow dynamics and engineering. And that's the design that we've been working with forever. But your own native valve is very different. This is an aortic valve. This is an image where they've eaten away most of the regular tissue and left the collagen bundles. And this 3-dimensional structure is important in this leaflet. Why? Because when you pull it in this direction, this valve is very stiff. As you stretch it, the tension goes way up. It's very stiff. But if you pull it in the radial direction, it's very elastic. Why? Because the leaflets come together and they actually push each other up. And so they increase the coaptation height. That's Mother Nature. We don't have anything like that yet. So what is going on right now in our field? There's a lot going on. There's a lot of interest in decellularization of native tissue. There's been interest in tissue engineering probably for at least 30 years. And then there's alternative methods of tissue preservation. Decellularization is one of the areas in different ways of cross-linking collagen. And that's been around for a while, the decellularization. The problem with decellularization is that it's basically a series of detergents that are applied to tissue. But the impact of that and how that destabilizes the collagen structure is important. And that's one of the things that's very difficult to control. And so from tissue to tissue, from valve to valve, you get different elasticity, different impact on the material. And so it's not as predictable that one valve will behave exactly the same as the next valve. And that's one of the strong limitations of that technology. Tissue engineering is just, the problem is, how do we drive biology to do what we want rather than what biology wants to do? And how do we get cells to actually behave in a way, when they're back in a blood flowing environment, behave the way that they work in a bioreactor? That's a challenge, and I think it will continue to be a challenge. What about polymeric valves? Well, polymeric valves have been around for at least 30 years. This is traditionally the materials that have been tried. PTFE, I think everybody knows about. This failed very quickly because of calcification. Silicones are interesting, but they become very stiff. The polyurethanes, the standard polyurethanes that were tried early on, also calcify very quickly and they fracture. The problem with fracture is you get a catastrophic failure. You get a fracture, that fracture propagates, the valve suddenly opens. You've got acute onset of regurgitation. That's a catastrophic failure. You can't have that. So that's been the historical approach. But the world continues to move. This is a list of this is just an incomplete list up until 2020 of the different polymers that are being tried for valves. And if you look at the number of publications in the polymer valve world, it's exponential. So this field is exploding. People are trying every single combination. And it's a lot of the materials are the base materials that we worked with 20, 30 years ago. The silicones, the polyurethanes, and EPTFE is all the same, but now we're beginning to understand how to work it so that it works better inside of the body inside. So there's novel polymer leaflets. The one that is out in clinic already and in clinical trials, this is the Foldax. This actually is a silicone polyurethane material, very complex material, but I believe it was originally developed at Caltech, and it seems to be very durable. It does need anticoagulation, so that's one of the problems. This valve, which is the Audis valve, is made out of EPTFE. So we're using an old material. But if you start looking around and see what's coming down the pike, these are all polyurethane or synthetic valves that are being developed. This is the Foldax valve that's coming around, but these are all being evaluated, some in preclinical, some of them are getting ready for clinical. So we're going to be seeing a lot of new stuff. And even complexity is being added. Now, you remember this picture where we showed you the collagen structure? This can actually be done in a number of different ways. You can add fibers to the polymer, or you can electrospin it in a way that, in fact, it has that reinforcement in there. So you can actually mimic a lot of biology nowadays. So that solves the material problem. It doesn't solve the growth problem. The growth problem is a whole different issue, and that is in order to address that, you need to talk about design. How do we design a valve that actually will grow with the child? And this is a graph showing both the aortic and pulmonic valves in a child. When you start off in a newborn, you've got valves that are roughly about 8 or 10 millimeters in diameter. Within about 10 years, they're going to have to double in diameter. So you need a valve that's able to do that in order to be able to have it not be replaced. And so this is where we looked at Mother Nature to understand how to do this, because there's a valve in your body that does that every single day, and that's the venous valve in your femoral vein. If you're laying down flat, that valve is about 2-3 millimeters in diameter, competent valve. You stand up, that valve becomes about a 7 or 8 millimeter diameter, still competent, and it has a whole water column that it supports. That design could easily be mimicked, and that's what this valve does. And so when it's empty, it still coaps quite well, but it doesn't form thrombus because of the recirculation around it. When it expands acutely. And so basically what we did was we just simply mimicked that. We had 2 leaflets and created a structure around it so that you could expand it and have it work. And so this is kind of how it works. This is its nominal size is 12.5 millimeters when it starts, but then you can begin to expand it, and the structure allows it to maintain its circularity, which is what you need. You need it to be absolutely circular. And keep on going. This is 18 millimeters now, which is quite a substantial increase. And it keeps on going, and it'll go all the way up to 22 millimeters in diameter and still function as a valve. Why? It's a very tall valve, lots of coaptation height when it's small, but then as you expand it, the coaptation height goes down. Very simple concept. Mother Nature figured it out in about 1.5 billion years. It took us a little bit less time than that to mimic it. And so this is how it would work. In this case, it doesn't expand by itself, but you balloon expand it. This is a lamb study where we're actually balloon expanding that valve. And this is when it's fully expanded. And this is an injection in the pulmonary artery of the lamb showing that the valve is competent. So that study was done, and now that is in clinical trials right now. What was done for that valve, though, is one of the things that we had to do for regulatory purposes. We have to understand where the stresses were of those leaflets. And unlike a 3-leaflet semilunar valve where the stresses are in the commissures, the stresses in this valve are actually central in the middle of the leaflet. And so that's one of the ways that we can understand how to distribute the loads so that the failure points can be predicted by using finite element analysis. And then we can design to optimize for that. And that, in fact, was done. This is a very nice study where they looked at, this is in humans, they looked at medical imaging data. They extracted the 3-dimensional geometry of the aortic root in these patients. They created a shell, and out of that, they came up with the ideal valve for that patient that actually distributed the loads very, very well. What's interesting about this study is it was published in Nature in 2019, almost 6 years ago. So it's been around for a while. This is not new stuff, okay? You can go even further, and this is where we would really like to do is understand flow dynamics, because flow impacts tissue in a very predictable way. The computational component of it is very challenging and takes a lot of computing horsepower, but you can do it. So you can predict a valve that's stenotic, that has a certain flow pattern, and as you calcify it, you can define the new flow pattern. So we moved pretty quickly. We've talked about a lot of stuff, but I want to end by showing you something that's I think is really interesting. So I took that image, which I think all of you saw. Oops, sorry, let me go back. And then I just took that image and I stuck it in ChatGPT-4 and I said, what is this an image of? And this is what it told me. The image appears to be a 3D reconstruction of an anatomic structure, likely created from imaging data such as CT or MRI. The structure in red seems to represent a portion of the cardiovascular system. And it goes on and on and on, and tells me a lot more about this. So then my next question was, this is an aortic valve. What is the problem with the valve? Aortic stenosis versus congenital malformation. It's a thickening, reduced mobility of the leaflets, and tells me what the problem is, et cetera, et cetera. So the technology to do this is here, okay? And the real change is going to come when you have a mentor in the operating room. You're repairing that valve. That mentor is seeing what you're seeing, is analyzing what you're analyzing, and is saying, based on what I'm seeing, you should be doing this. But that mentor isn't your senior colleague. That mentor is actually an algorithm. And I think that's just where we're going to go with this. This is where this is going to happen. So I'll stop there and answer any questions. Again, thank you very much for the opportunity.